Hello everyone, I'm Hao Liu from the University of Pittsburgh Medical Center. I'm honored to present to you our case series of pancreatic-portal vein fistula, PPVF. PPVF describes a fistula connecting the portal venous system and the pancreatic duct system. First described in 1966, less than 50 cases were ever reported. PPVF is associated with high morbidity and mortality with a wide range of presentations and outcomes. Our series of 13 patients represent the largest cohort of PPVF reported from a single institution. The natural history of PPVF starts with pancreatic enzyme leakage, resulting in severe inflammation, digestion, weakening, and rupture of peripancreatic blood vessels. Due to the portal vein's proximity to the pancreas, autodigestion of the main portal vein can cause wall weakness or local defects, forming the anatomic connection between the pancreatic duct system and portal venous system. Searching through clinical, pathology, and radiology databases, consecutive cases of PPVF at UPMC from 2008 to 2020 were retrospectively identified. Clinical courses and outcomes were summarized. A total of 13 patients were diagnosed between 2008 and 2020, with 10 diagnosed since 2017, suggesting that PPVF might be underdiagnosed. 9 patients had chronic pancreatitis, while 4 patients had acute pancreatitis. In patients with sepsis, 1 patient underwent surgical necrosectomy and survived, while 3 or 4 patients without debridement died. Of the 5 patients who died, all had occlusive or near-occlusive main portal vein. 7 out of 8 survivors had a sub-occlusive or patent main portal vein. Among our 13 patients, Case 4 highlighted the characteristic imaging findings and diagnostic and management strategies. In this patient who presented with pancreatitis, the diagnosis of PPVF was made through CT. We can see a typical portal vein filling defect contiguous with adjacent acute necrotic collection, with corresponding high T2 signal filling defect in MRI. Later, transhepatic portal venography showed portal vein filling defect that was biopsied to be necrotic tissue. Intravenous ultrasound showed portal vein wall defect and the extension of necrotic material into the lumen. This patient received a percutaneous transhepatic portal vein endograft. However, she passed away from sepsis due to colon perforation. There's no standard treatment algorithm for PPVF. Generally, interventions are made to address severe acute complications. Of note, we treated 2 patients with a novel use of transhepatic PV stenting in PPVF for acute hemorrhage or high risk of hemorrhage. In these 2 patients, vascular stent placement represented an alternative that allowed for survival in the acute setting, preventing mortality from exsanguination. In summary, PPVF is a potentially life-threatening and possibly underdiagnosed entity. Occlusive or near-occlusive main portal vein filling defect and sepsis correlated with high mortality rates, and early clinical suspicion and timely diagnosis may facilitate optimal treatment.